Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, let's talk about some choices for empiric antibiotics in really sick patients. This show has been just sitting in the back burner for quite some time, and then I got a contact from David Talan. And if you don't know David Talan, he is an EM doc, but also a trained ID doc. He's done amazing work on things like community-acquired MRSA, COVID, vaccines, all sorts of great stuff, numerous publications. Super brilliant guy. And he's like, Scott, I don't think people in EM are aware enough about the fact that the cephalosporins may not be enough to treat bad urosepsis. And we should be talking about that. And I'm like, Dave, why don't we get you on the show and we'll talk about that and basically all the other empiric antibiotic choices for 2026. So that's exactly what we did. And that's what you will hear shortly. Now, real quick, before we get into that, I just want to mention we have spots opening up in our Resus Leadership Academy. That is the project I do with Haney Malamet, and it is basically a Resus fellowship that you could do without having to give up a year of your life, without having to give up your earnings, without having to change jobs. So you do it virtually. There's an entire curriculum. You meet with professors monthly to talk about your cases. You meet with me monthly to talk about all sorts of things in ED critical care. It's pretty fantastic. It's one of the most enjoyable things that I do. And now we have spots open again. Every person who has graduated has come out, and they are now like the leaders in resuscitation in their department. That's why we call it that. That's why it's the Resus Leadership Academy. So if that sounds intriguing, if that sounds interesting, if you always wanted to pursue a resuscitation fellowship or a critical care fellowship, but you're just too far in life, you have kids, you can't go back to shock trauma like I did, then this is something to consider. So if that sounds interesting, then come to Resus Leadership Academy, all one word, resusleadershipacademy.com, and check it out. You could ask for more information. We'll send it to you, and you could evaluate whether this is the life change you'd like, whether you'd like to really be the master of all things resuscitation in your department. And we bring in emergency physicians, but we also bring in hospitalists because there's a lot of hospitals that are doing critical care and would like additional training to be able to take care of their super sick patients because they're covering the ICUs, even though they've never had an ICU fellowship. So that's another group that I think has really loved it. We've had paramedics, we've had NPs and PAs, but our bread and butter is emergency medicine who wants to just up their game in resuscitation. So resusleadershipacademy.com. All right, so back to the show. Before we get to David, let me contextualize this. So we are going to be talking about empiric antibiotic choices in patients from the community, not hospital-acquired bugs. We're going to be talking from the community, and we're going to be talking about sick patients. So either sepsis or septic shock, not your regular pneumonia that's being seen in the main department. These patients are pretty sick. So, just as a little prelude to what we're going to be talking about, because this is kind of a soapbox issue for me, the mortality difference from antibiotics is really only seen clearly in the literature, in my estimation, in patients who are hypotensive. So infection plus hypotension equals you better get antibiotics in damn quick or they start dying for each hour that you waste not getting them the antibiotics. So those patients we need to move with alacrity. In patients who aren't hypotensive, the evidence really is not strong at all for a clear associated need to move super expediently for patients with a lactate greater than or equal to 4. So our classic septic shock definition in 2026 of hypotension or super elevated lactate, I think those patients need antibiotics really quickly. Now, sepsis patients is not quite as clear. There may be an association, and I really strongly emphasize that word, association, at the 3-hour mark, but certainly not the 1 hour that's being talked about in the various surviving sepsis campaign iterations. That 1 hour just doesn't exist for real evidence. There's an association at 3 hours, and even that's not necessarily causative. And David and I will talk about the reasons why it's an association and not necessarily causative in just a bit. So I could buy it in an actually sick septic patient, but we've watered down sepsis so much that now we are calling things sepsis that for me, it's just an infection. Things with these vague lab abnormalities are now being deemed sepsis. And so I don't know if you're going to really treat these patients the same way as you would in a patient who's hypotensive and clearly going to an ICU. So in my mind, there's ICU sepsis, and then there's sepsis that you might put on a regular floor. And in those patients, I don't think you need to move as quickly, though as soon as you determine there's an infection, obviously you give the antibiotics. But if you're still in a contemplation phase or it's not really on the radar screen that this patient's definitely infected, then you can spend some more time working it up. So that's my initial contextualization. So we're talking about sick patients from the community. And then let's get David on and then we'll go from there. The first question I'll ask you, David, is the question I ask everyone: Who are you, and what do you do?
Yeah, thanks, Scott. Yeah, so I'm an emergency physician. I've been that all my life, but somewhere along my career, I was thinking about being a research cardiologist of the endurance athlete. So I had to do an internal medicine residency to get there. I did rotations at UCLA Emergency Department. I got excited about emergency medicine and thought about an academic career. When I trained in emergency medicine, it was before Hib and pneumovax vaccines. And I remember regularly seeing sick children with bacterial meningitis. And I just thought that was the most awful thing. And then if I was going to plan an academic career, maybe I should focus on infectious diseases. So I went to this county hospital affiliated with UCLA called Oliveview UCLA as an EM faculty. And I wasn't married and I didn't have kids. And I decided to do an ID fellowship and took all my shifts at night and on the weekends. My group was doing other fellowship, man. Keep going, baby. And so I wound up having this rare combination of medical backgrounds, being an emergency physician primarily, and an infectious disease doctor. And I've spent really the rest of my career talking about, thinking about, researching that intersection.
Absolutely. I love it. Now, we have many topics on our plate to discuss, but I figured I'd get you in the mood first, David. I know you have within you some rants, some real things you want to get off your chest. Here's your forum. When they say, oh, the ED doc delayed antibiotics on this septic patient, it's because they were lazy. They were probably eating a long lunch. That's right. That's what goes through your mind, right, Dave?
Yes, that's exactly it. Why do we call a longer time to antibiotics this sort of Monday morning quarterback thing or something described in studies as delay? I believe that emergency physicians know best how to distinguish sick, not sick, septic, not septic. If you guess septic as an ICU doctor, you're going to be right most of the time, almost all the time. But down in the ED, we have to sort patients. And the challenge is, and the difficulty that everyone should recognize, is that many of the patients at greatest risk of sepsis are the very ones that don't overtly manifest the signs of sepsis. In a lot of patients, this is hard.
Absolutely. And in fact, we have evidence for this. We have evidence that in the patients who antibiotics are delayed, it is often because they were not immediately obvious as sepsis. And the reasons why are associated with that patient's mortality, not the delay in antibiotics by the studies I've seen. Meaning, you get a cirrhotic patient and they might be hypotensive and vasodilated and warm, and that's their natural state. And figuring out if they're septic is very hard. Cirrhotic patients die at a much higher rate than the normal population. So the fact that you did not diagnose them immediately and give them antibiotics is because of their underlying state, not because you did not care, not because you were lazy, not because you had other things on your mind. It's because some patients are really hard and those patients have a higher chance of dying.
That's right. And that's why a lot of these cohort studies where we try to tease out what the relationship of time to antibiotics to survival is are very difficult to untangle. Also, the most complicated patients have been in the hospital exposed to antibiotics, and they're more likely to have a very resistant organism that wasn't initially covered. But that's what we're going to talk about is how to anticipate that better. And I think this is a good opportunity because on our friends' podcast, MRAP, a lot of focus has been on these trials comparing Vanco and cefepime and Vanco and piperacillin and tazobactam. And I'm going to tell you for gram-negative sepsis, which is absolutely the most common and important type of sepsis, those gram-negative antibiotics often are not the optimal antibiotics. And I'm going to explain why in a little bit.
I love it. All right. So before we get into actual sites, you have a kind of a framework you use to make antibiotic decisions. And there's a lot of S's in here, like site, species, severity, how scared you are, and then special cases like patients with splenectomy. What is your general framework as an ED/ID doctor, David, to decide which antibiotic is right for the patient?
It's sort of an equation. Let's pose this first. After you've determined the patient's likely infected or septic, okay, which is guided by the source of infection so we can understand the bacteria. That's what we're usually talking about. that are likely involved in severe sepsis with those sites of infection, their resistance patterns, what we know about that, how sick the patient is. Because I do think how fast we give antibiotics probably is related in part to how sick the person is, but not only how sick they are, how susceptible they are to going south, even if they don't look sick right at the time. And then the resistance patterns and the anticipated therapy for those resistance patterns. And then you mix in not only the risk of giving an antibiotic that's not active against the causative bacteria, but also your risk tolerance for being wrong and the consequence to the patient. So you have to put that all together. And the place that I start is with a good chart dive, which is a good place and doesn't take too long. And what am I looking for? I'm looking for past hospitalizations, where they've had infection or sepsis before, what organisms have been isolated and their resistance patterns, because like they say on those commercials for financial investments, past performance in this case does predict future results, right? They warn you it doesn't, but in our business, it really does. So it pays to spend some time in the chart. I'm also looking for comorbidities, sometimes which patients neglect to mention. Oh, that midline laparotomy scar was a traumatic splenectomy. Okay, now that person's persistent tachycardia and borderline temperature elevation means a lot to me. I better get going. So that's where I start. And then the next step is to do a good history and physical exam, and then laboratory tests and imaging to help identify the site of infection. POCUS can be somewhat helpful for like deep organ infections and stuff like that. We start out with chest x-ray and in the appropriate patient, abdominal CT. In a patient who has symptoms of pneumonia, but you see a negative x-ray, I might CT the chest to get a better idea about what's going on. In a patient who is extremely at risk because they're neutropenic and I can't find the source, that's a patient where chest CT might be very helpful to even identify a potential fungal infection that needs treatment. And mainly, we're going to be talking about bacterial sepsis here. And then I go from there. I go from there thinking about what are the organisms associated with that site of infection that are the most likely to kill the person. And then I anticipate the resistance patterns to craft an antibiotic regimen. But I don't give everybody Vocit. And that's what's done, or it's just not talked about in any type of treatise on sepsis by learned people. You and I are going to talk about it.
All right, so let me review all that. So your initial workup, you're going to do your history and physical, obviously. You're going to do a chart dive looking for things like patients' prior culture results, prior infections, why they're in the hospital, any other special circumstances they have. And you're also going to determine the need for imaging. Now, I have a super low threshold for imaging in sick patients if I don't have an obvious source, especially because you will rapidly discover that many patients who have the symptomatology of a pneumonia and then a normal chest x-ray, when you get the CT scan, will have a whopping infiltrate that was not seen on said chest x-ray. That has happened so frequently as for me to really question the high sensitivity we used to attribute to chest x-rays. So if I don't know what the hell's going on, and we'll talk about this later on in the empiric antibiotics section. But if I don't know what's going on, the patient in general is getting a chest CT and follow through to the abdomen so I can figure out what source they're actually hiding from me. All right, then we talked about the 5 S's that Dave mentions: the site, the suspected site of infection, the species, what bacterial species you think it could be, and that will go into resistance patterns of the area you're in, the antibiogram of your hospital. You've seen your biogram, right? Like you have it for your hospital. It's not just ID and it's never shared with the actual clinical departments. Go get it. If you don't, it's there. The ID folks always make it. You need to know what the resistance patterns are for your hospital. And then the patient's prior infections and cultures. The severity of illness is the next S, the severity. So how dangerous is it if you're wrong? And this speaks to both how sick the patient is and also the site. Like if you miss a few hours of a bacterial meningitis, it is devastating. If you miss a few hours of a lung infection, it could kill the patient, but it's not going to kill them necessarily as quickly as a bacterial meningitis. How scared you are is the next S. your risk tolerance. What is your cutoff for being wrong? If you hear that there's a 5% chance it could be an extended spectrum beta lactamase, are you okay giving that patient ceftriaxone? Or is your number 10%? Now, you're not going to have exact percentages given to you, but your risk threshold will determine how broad you are treating most patients. And then special circumstances, things like splenectomy, neutropenic, immunocompromised, etc. So those are the 5 S's: site, species, severity, scared. Are you scared? Special circumstances. All right, let's talk renal dosing. Don't renal dose on your first dose. I cannot be any more clear about this. This is a true teaching point. First dose given standard, and then you renal dose on the second. It might be a reduced dose. It might be an extended time until that second dose. But what it is not is a change in the first dose. The first dose establishes plasma levels, does not get affected by your patient's renal status. Second dose, I call this second dose syndrome. We don't give it in emergency medicine for the most part. We write orders for a single dose of antibiotics, and yet they board with us forever, and the hospitals haven't necessarily taken over on the patient yet. The intensivists haven't not necessarily taken over, and the patient misses their second dose, or it's significantly delayed. That is not cool. You really should be writing the dosing so that the patient gets continuous dosing. And then the inpatient team could just cancel that order, but you should be writing, meropenem, 1 gram Q8, not meropenem, 1 gram IV times 1. Because you will miss that second dose in many cases. So second dose syndrome should not occur. Dose your second dose continuous doses, and then the team could change the order rather than ordering that second dose. All righty, let's get into the sites of infection. Now, Dave, the reason you wanted to come on the show in the first place pertains to urinary infections and the fact that ceftriaxone is the prevalent drug being used even for really sick patients, and you disagree with that. So tell us a little bit about extended spectrum beta lactamase bacteria and what we should be doing in your estimation.
So the first treatment we're going to give, and this has actually been found in clinical investigations, is aimed at gram-negatives. And here the resistance problem in the community. Now, we're not talking in the ICU or carbapenem-resistant organisms running around. We're talking from the community. The biggest problem with gram-negatives is the emergence of extended spectrum beta lactamase producing Enterobacterales. It used to be called Enterobacteriaceae, but all that means is E. coli and its cousins, which account for 90% of these infections, okay? And we did a study through our CDC network, which I'm going to plug. It's been in existence for 30 years. It's like a permanent part of the US public health system. We were credited with recognizing the emergence of MRSA. Important, right? We used this network in the late 2018, 2019, to look at all patients with urinary tract infection admitted through these emergency departments. A third of them met sepsis criteria, urosepsis, let's call it. And we found that 90% of these infections were caused by Enterobacterales, and about 20% of them were due to ESBLs. In over half the cases, the initial empirical antibiotic in the ED did not have in vitro activity against the causative organism. Let's back up and say, is that important? Yes, that's associated with a 5-fold reduction in survival. Okay? So not only giving antibiotics fast, but giving the right antibiotics. Why did this happen? Because we are so in love with our old friend for every type of infection, ceftriaxone. And ESBLs are resistant to every common cephalosporin. They're even highly resistant to cefepime, and they don't work very well for piperacillin tazobactam, which you think would work because it has a beta-lactamase inhibitor stuck on the end. There's been randomized trials, at least one, and other supportive evidence, showing a significant mortality reduction for people with ESBL bacteremia where they compare meropenem, and this is the antibiotic I'm going to say we should think about, versus piperacillin tazobactam. And Scott, don't believe me. If you respect the Infectious Disease Society of America, their guidelines say, if you have an ESBL, if you have a serious ESBL infection, the drug of choice is meropenem. This is not in our lexicon on MRAP. Nothing against MRAP. I love these guys. They're all my friends like you. And they focus on what's in front of them, like these studies, but you have to put this all together. Now, not every place has high ESBL rates. We found a variation from, I don't know, 5 or 10% to 45%, of course, in New York City. But this was 8 years ago. And every other place in the developed and undeveloped world, you see very high rates in the community. So everybody needs to know that. If you have somebody sick with urosepsis, certainly if they have any of the risk factors for ESBL, but even if they don't, if they meet your threshold for someone, I don't want to see the consequences of being wrong. Your gram negative should be meropenem. The other really important thing about meropenem is the gram positives with urosepsis is enterococcus, and meropenem is active against enterococcus. Meropenem can be pushed, reconstituted by an ER nurse and pushed over 5 minutes. So if you're looking at the clock with the CMS pay per performance, like that's something to be taken care of.
All right. So risk factors for ESBL: a blood or urine culture with a resistant organism, ESBL organism in the past 12 months, fluoroquinolone use, or I think in general, the antibiotics within the past few months. Really sick patients are not a risk factor for it, but the risk of missing it is obviously much greater in a really sick patient. So you might consider it there. What other risk factors are you considering for treating for ESBL?
Here's an interesting one: travel to almost any place in the world, probably except Scandinavia. It's probably too cold. But like anywhere in the world, especially Southern Europe, South America, Africa, Southeast Asia, rates of ESBLs are like sky high. So that would be a risk factor if the person comes back with this mild form of sepsis. But in the absence of that, I think you could treat with ceftriaxone and expect it to work. Again, it all depends on everybody's sort of risk tolerance for being wrong. You can be wrong. When we studied this in our network, looking at patients admitted through the EDs for urinary tract infections, I think we found that about 90% had some risk factor. So is there a small chance that they could have an ESBL? And oh, by the way, that study was 8 years ago. So now ESBL rates have to be higher.
Okay, I love it. So what I'm hearing is if they're sick, give them the meropenem. If they are not that sick, then start looking for risk factors. If they don't have any, you might just be able to get away with the ceftriaxone. Okay, so then just to finish out urinary tract, a couple more questions. So is there ever a situation we need more than meropenem to cover gram positives? I know people have a urinary source and they're empirically throwing on Vanco. It doesn't make a lot of sense to me in most cases. What is your feeling on that? Is meropenem enough to cover? And then let's say you didn't worry about ESBLs. How would you be covering your enterococcus in that case in a patient who's really sick?
Think about it. We talk about covering your ass, but not about covering your enterococcus?
Oh man, we're getting a host of ID humor here. That's fantastic.
Do you think we'll get mail?
No, not on this podcast. Maybe on MRAP, but no. EMCrit, they know what to expect.
Yeah, I think that's another really nice thing about meropenem because it has activity against enterococcus. So you wouldn't you'd have one drug. And if you're giving vancomycin in addition to meropenem, like that is unnecessary. On the other hand, if you use cefepime, the cephalosporins are generally not active against enterococcus. You would have to add vancomycin to cover enterococcus. Again, it's not a common cause, but it is one of the next most common causes. And if you're worried about being wrong and the consequence to the patient, then using cefepime, which is an inferior treatment for ESBLs, would still require that you add another drug. Meropenem doesn't require that. Meropenem is also anti-pseudomonal. Again, sometimes you see this, but it's generally very rare. So I think right now, meropenem is a very useful drug for us up front.
Love it. All right. So let's sum up a urinary source for sepsis. So you have to cover the gram negatives, and the one you're going to worry about is the extended spectrum beta lactamases, things like E. coli with the SBL. And then the gram positives. And the gram positives you're going to get from the community that you should worry about are Enterococcus faecalis, which is annoying that they pronounce that one with a hard C, and then faecium, which we'll talk about in a second with a soft, but that's just the way it is. And in Enterococcus gram positive faecalis, Meropenem's okay. It's not great, but it's okay. So a single coverage, you probably get away if you gave meropenem. If on the other hand, you gave something like ceftriaxone and they did turn out to have enterococcus, you're probably not covering them very well at all. Now, the other one you'll hear about, it's more of a hospital-acquired bug, and that's Enterococcus faecium. And that's where you see the VRE, the vancomycin-resistant Enterococcus. And in that case, meropenem will not be adequate. But in the community, which is what we're dealing with in this show, meropenem will probably cover it. So where does that leave you? It leaves you with, if they're really sick or they have risk factors for ESBLs, things like prior cultures, blood or urine, exposure to antibiotics like third generation cephalosporins and fluoroquinolones. I'm not sure if the travel one really meets the threshold, but I guess it's something to keep in the back of your mind. Or the patient is really sick and therefore missing it would potentially, be not cool. Patients go into the ICU. For those patients, I give meropenem. And I give a relatively high dose of meropenem to hit that ESBL bacteria. So meropenem 2 grams IV. And then you could argue what the second dose should be, whether it should be, again, 2 grams every Q8 hours or 1 gram. But that first dose, I give meropenem 2 grams IV to my patients who are going to the ICU or they have risk factors for ESBL. The rest of my patients, ceftriaxone, 2 grams, Q 24 hours. Now that's nice. And I've made that shift for a lot of my patients when I'm using ceftriaxone, is that 2 gram dose means you don't have to worry about the second dose. It's going to be someone else's problem at the 24-hour mark. And so it's a really good thing because it means you can get something in, know you're getting coverage for an extended period of time. So meropenem or ceftriaxone, we've talked about which one to use when. You do not need to add things like vancomycin or other gram-positive coverage unless something in the culture sends you that way, especially if you're using meropenem because you're going to get that community enterococcus coverage. Okay, so abdomen was the next one I wanted to move to.
You take urinary tract, and you could say the same for intra-abdominal, right? Because the bugs are the same. So I don't think the considerations for intra-abdominal sepsis are much different, other than the fact that source control rises to the top there, where you don't generally have that with urinary tract sepsis.
All right. So is abdomen the same as urine? Are you also giving sick patients meropenem in that case?
Yeah.
Hey, folks, but we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this. And now 8 minutes from now, you're going to be listening, super excited by what you're learning. And then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
I think so, because the bugs are the same.
Yep.
Now, bugs like enterococcus, which sometimes, people overlook as a pathogen, becomes actually a real pathogen, not just something else you find or culture. In cholangitis, which makes people real sick, that's number 2 under E. coli. And so for the same reasons, I think in the right patient who's sick and susceptible, meropenem is an appropriate empirical choice because of the concern with the ESBLs.
Now, that would be a big paradigm shift. I've seen, I think in the intensivist community, we got in urinary tract infections, meropenem, but because the surgeons now are the people you're talking to on the abdomen for the most part, Zosyn is so omnipresent as to be, there's nothing else.
I guess we should also mention that drugs like piperacillin, tazobactam, and meropenem have anaerobic activity. And we debate the need for anaerobic activity more with like lung infections, but there's no doubt that can be extremely important with intra-abdominal infections. Cefepime, for example, is not a drug with anaerobic activity. Piperacillin tazobactam is ideal in many ways. It is active against Enterococcus, being a penicillin. It's active against anaerobes. It's broadly active against gram-negatives, but it does not perform as well if you're unlucky enough for your gram-negative cause of your infection to be an ESBL producer. Now, Don't get me wrong, the most important thing with intra-abdominal sepsis is source control. And watch out if surgeons latch on to meropenem because they'll be giving it as preoperative prophylaxis. But in a septic patient with a serious intra-abdominal infection, for the same reasons we discussed with urosepsis, I think meropenem is the logical choice for many sick patients.
All right, let's sum up abdominal/GI. We're talking severe infections here. We're not talking about the appendicitis waiting to go to the operating room. So in a patient who is septic with an intra-abdominal source, and the one that scares me most is ascending cholangitis, so that's the one that's in my mind as I think about this, I don't know what to do. I'm sure David has a valid point that this is pretty much like urine. You should be worrying about the ESBLs. But most of the societies making recommendations are not willing to make that jump yet. And they're still recommending piperacillin tazobactam, which would be a higher dose than you might be used to, and it's given in a way you might not be used to. But I think what you're going to see in a lot of the cephalosporins and the carbapenems and the sick patient penicillin drugs of a extended infusion rather than a simple push for things like this. And so the doses I've seen most commonly and in the sources that I trust would be Zosyn, piperacillin, tazobactam, 4.5 grams IV Q8, but given each of those doses over 4 hours. So you get an extended kill time on this. And this makes all sorts of drugs in the classes I just mentioned more effective. So that's one option. Now, if you're worried about ESBL, and again, that would be a patient with prior culture results or on previous antibiotics, then I think the meropenem, as David mentioned, is a fine choice, just like you would for a urinary source of severe sepsis. But I still think in most patients, I'm going to be starting with the piperacillin tazobactam, and then I'll have that niggling consideration of, should I have given the meropenem? Should I have given that meropenem? But there you go. All right. What's next? Okay, let's go to lung. Patient, community-acquired pneumonia. They're sick. What do we give them?
Okay, so we know the killers with community-acquired pneumonia, and number 1, 2, and 3 is pneumococcus. And pneumococcus is also the most common cause of bacterial meningitis, right? And think about how we cover for that when we give antibiotics for bacterial meningitis. We give ceftriaxone, but there's some pneumococci resistant to ceftriaxone. So we add vancomycin. So you're going to add vancomycin. Also because second on the list is staph. And I'm sure in your critical care experience, you've seen some terrible cases of staph pneumonia. And even when you give all the right drugs, like these people stay like febrile and bacteremic for days. It is, Staph aureus walls itself off. It is a bastard, right? So it's hard to treat, but that's second on the list. And then like things like gram negatives are unlikely unless the patient's already had a trip through the hospital and the ICU. And occasionally you'll see Legionnaires, right? And that can come from the community. It's rare, but it's covered by the other thing that is a backbone of empirical pneumonia treatment, which is azithromycin. If you're really uptight about Legionnaires, there's a lot of GI symptoms or the patient is a veteran or something staying at a hotel in Philadelphia. So ceftriaxone azithro is our core. We're going to add vancomycin, and that's all you need. Tazo, cefepime, do not factor into this equation.
Now, some of the infectious disease societies are not recommending empiric vanco just for being septic. Are you giving it in your practice regularly? You'd rather not take the chance of having a MRSA or a resistant pneumococcus? I want to hear actual clinical practice, David. Are you giving vanco on every patient who's septic or just every patient who's septic shock?
Yeah, it just gets back to your risk threshold, right? We've said they're septic, and in the course of this discussion, we described like barely septic patients and extremely septic patients. So you judge for yourself. But yes, there are people, experts in ID, and IDSA guidelines that don't automatically say give vanco. There's a lot of hand waving. Oh, think of it if they've got abscesses in their lungs or empyema, or it's following influenza. I don't know. It's even if you confine yourself to pneumococcus, if you have a sick patient, the same reason we give vancomycin for bacterial meningitis would be the same for a bad case of pneumonia. There are pneumococci resistant to ceftriaxone. I'm okay with giving vancomycin.
Question on that. What about linezolid? We know it has better lung penetrance. The antibiotic stewards might not be as happy, but assuming that we're just giving one dose and then figuring it out after, is linezolid a better choice in 2026?
You asked about linezolid.
Yeah.
And that's because you're smart and you read the literature. And the literature says in comparisons of linezolid and vancomycin for staph pneumonia, the patients do better. I don't think a mortality benefit has been demonstrated, but why do you give norepi instead of dopamine? It's not, there's a clear mortality benefit. But the studies fairly consistently show that patients have a faster clinical cure with linezolid compared to vancomycin, as well as microbiological cure, clearing the staph. And it's hard to clear staph, and that's probably also a reasonable supportive surrogate marker for activity. I don't see the stewards getting all uptight about linezolid. And this is one of these things where if you gave linezolid in a case of severe pneumonia, particularly if it had features of staph, I think you'd get a lot of respect.
All right. So
we're all about respect, man.
That's all we want. There are various scores to determine a patient's MRSA risk. Do you use any of those? And that might be a determination of linezolid over a vanco, or do you not find them utile?
I don't find them helpful.
Okay. So then what makes you say, this patient's kind of smelling like a MRSA pneumonia versus a standard cap?
How sick they are.
Okay. So that would be your determination. Gotcha.
Yeah, how sick they are. There are more specific findings that could do that, but you risk not covering this. One of the things that's used in some places, you may be familiar with this, they might even use this at your hospital. You can do it as a point of care test. The lab can turn it around, but you can sample the nose to see if the patient has MRSA. And in general, that works, but the problem is the predictive value falls apart because in a very severe case, compared to where this paradigm is usually studied, all bets are off. So I don't think you can rely on that. In general, for any pneumonia patient, that's pretty good to help rule it out. But if you take someone sick with community-acquired pneumonia, really sick, then the chance of being wrong becomes too great, even with point-of-care screening for nasal MRSA. If you want to play the game, okay, let's see if they're low risk enough, or I'm not going to give it, knock yourself out. But at the end of the day, it's your patient. And you're probably seeing them as when they're maximally sick, about to get very sick. And so that's our responsibility to make that call.
Absolutely. All right, that makes sense. Now, healthcare-associated pneumonia has disappeared. Is there any consideration, unless the patient's been in an actual hospital recently, that would make you change that antibiotic regimen we just spoke about?
Are there patients at risk and colonized with some very severe bugs? Yes, and you'll know that through your chart dive. And for those patients, I'd pay attention. There's some crazy resistant shit out there, man. And so it pays to read the patient's diary of recent past experiences. There are some patients with such resistant organisms, it's okay to call a friend and actually call ID, although you're not going to see many of us in the ED, except if they're like me or Greg Moran, because that is our home, right? So yes, I would say for the most part, HCAP used so broadly as it used to be is not generally applied except in some special circumstances.
All right. Love it. Are you empirically giving steroids in 2026? I know I am if they're sick enough to be septic.
I am too. I'm pretty convinced where this is all going. In fact, you can show outcome differences better with pneumonia than you can with septic shock, I think.
All right, let's review lung. So your backbone, ceftriaxone, 2 grams IV, Q24 hours, and azithromycin, 500 milligrams IV, Q24 hours. You could substitute, and there's many good reasons why you might want to, doxycycline for the azithromycin. That would be 200 milligrams PO or IV, and then 100 milligrams PO or IV Q12. Doxy gets you potentially some community-acquired MRSA coverage. It does a wonderful job on the atypicals. It does a good job on strep pneumo. So not a bad option. So one of those two. So ceftriaxone plus some atypical coverage, either azithromycin or doxycycline. You should send an atypical workup on most of these sick patients. Now, that's usually going to be a Legionella urine antigen, but sputum PCR is actually better, though you now have to have the patient collect that sample, which most people, they'd rather just collect the urine. But if you have a sick patient, Legionella is on the option tree. It's why we do give the atypical coverage. All right. Your next question is, do they need pseudomonal coverage coming from the community? So there is the drip score that's been validated, and you can take a look at that. There's an MedCalc for that, and there's an MD Calc for that I have linked in the show notes. So that's one possible score that would evaluate pseudomonal risk. It also could help you with MRSA risk, which we'll talk about momentarily. But other things that should make you think about Pseudomonas is they've had that isolated from the respiratory cultures within the last year. Recent antibiotic use in the last 30 to 60 days. Some would say only IV antibiotics count. That's a point of contention. Hospitalization in the last 60 to 90 days. Some would say only if they got antibiotics during that hospitalization. Certainly I cover if the patient's neutropenic, if they've had a solid organ transplant less than 1 year ago, or they are being treated for rejection now, or they had a stem cell transplant less than 1 year. And those come from the Stanford antibiotic guide. I've linked to that. That is a fantastic resource. Their bugs and drugs section is really well done, and it informs the Stanford guide recommendations on this same stuff. If you do worry about Pseudomonas, then change from ceftriaxone to cefepime 2 grams IV Q8. The next question of similar ilk, do they need MRSA coverage? And this is it's a bigger one because these patients we are talking about are only sick. And if you miss a MRSA pneumonia in a sick patient, they're not going to do so well because MRSA is bad. Now, I've taken from the Internet Book of Critical Care, Josh's decision tree for do you need MRSA coverage? And he is using the SHORE score. So you can see what that is in the show notes. The SHORE score of 6 to 10 gets you MRSA coverage, or patient has cavitary pneumonia. They have post-influenza pneumonia. They are an IV drug user. They have skin pustules that look like MRSA infections on their skin, or they have known prior colonization with MRSA. Then you could give them a dose of an anti-MRSA antibiotic and then downgrade subsequently by, as David mentioned, using the nasal swab PCR for MRSA, which doesn't have a great positive predictive value, but its negative predictive value is excellent. It's an excellent negative predictive value. So if they have no risk factors, but they're super sick, you could give them one dose, get the nasal swab, and then if it's negative, just don't give any more doses. And I think that's a fine strategy. So if you are going to treat them, what should you give? And Vanco is the standard answer. Linezolid is probably better lung penetration. And as long as they don't have risk factors for serotonin syndrome, it's probably the better med. You have to make sure your ID folks are fine with that. But giving one dose of linezolid, getting the nasal swab, and then not giving any more if their nasal swab is negative, I think is a fantastic strategy. Now, 5th generation cephalosporins, and I'm going to pronounce these wrong, I'm sure, ceftobiprole, oh, Jesus fucking Christ, ceftriaxone, either of those will cover your MRSA as well as all the other stuff that your cephalosporins, your 3rd generation cephalosporin was covering. So that you don't need the ceftriaxone plus, just one of those would be enough. Now, I don't have access to these. I don't get to play with these unless I talk to ID. So they're not going to be used in my standard admissions. Do they need anaerobic coverage? The answer is no. No, they do not need anaerobic coverage beyond what they get from their drugs we've already spoken about. They do not need specific anaerobic coverage. But Scott, they aspirated. I don't care. All of these societies now are pretty much in line with this, I think, and as well as the major sites that I respect, like the Stanford guides. You don't need it for standard aspiration pneumonia. The ceftriaxone will absolutely cover you for a patient who aspirated from oral flora. And I don't care if they've colonized with other stuff. You're going to be fine. The only time they're recommending actual specific anaerobic coverage is when the patient has structural pathology found on imaging, things like empyema, necrotizing pneumonia, or lung abscess. Do they need steroids? Well, David and I both agree. For me, if they're going to the ICU, they get hydrocortisone 50 milligrams IV Q6. If they're just going to a regular bed in the hospital, that's a more debatable issue. I don't have a clear answer on that. Do what your heart tells you to do. I generally don't give steroids just for a patient coming in for pneumonia, but certainly if they're sick enough to need an ICU, then I'm giving them steroids. Whew. All right, let's move to skin. What in 2026 is your empiric coverage for a patient with severe skin infection or neck fash?
I guess the first thing I'd say is like your typical cellulitis or skin abscess. That is not usually associated with severe sepsis.
Absolutely. Yep, absolutely.
Right. So I think we're mainly talking, it's not to say it couldn't happen, but we're mainly talking about neck fash. So I think the antibiotic, you're going to cover broad spectrum, and here, obviously, source control. This means when you see one as an attending physician and your resident says, should I call a surgery consult? You go, no, you're going to get little cat A talking to little cat B. I'm going to talk to the attending to come to bedside to look at this with me because we got to move fast. That's the main thing. You're going to use a broad spectrum regimen. You may not feel comfortable only giving penicillin for strep and adding clindamycin. I get that. These patients are going to wind up getting IVIG. If you really suspect group A strep toxic shock syndrome, that would be a nice touch. As an emergency physician, to do that, someone will push back, but then they'll say, yeah, we better give the patient their best chance. I think for mixed infections like Fournier's, it still makes sense to add one of those anti-protein synthesis toxin shutting down antibiotics because sometimes Clostridia is the cause, and that's a toxin producer. And although I don't think there's evidence like there is for group A strep, it does make sense to me. And that's an infection that has terrible consequences. So those would be some of my antibiotic suggestions for severe sepsis associated with skin infections.
Quick review of skin, and primarily we're talking about nasty necrotizing soft tissue infections. You're going to give all three of piperacillin tazobactam, 4.5 grams every 8 hours. And you're going to give that as an extended infusion. I think these patients don't want to take any jokes, so you give them the best possible. Or you could substitute meropenem. But I think standardly, most of us are still given the Zosyn, though meropenem would be fine. I think you should not be giving Vanco. I think you should be giving linezolid unless they have contraindications because it's going to be in quicker and it's going to potentially have the antitoxin effects. So that's linezolid 600 milligrams IV Q12, and then clindamycin 900 milligrams IV Q8. Some sources recommend even higher at 1200. I'm still giving the clindamycin 900, and that's primarily for antitoxin. Now, if the patient has suspected Vibrio or Aramonis, they need different antibiotics. I'm not going to discuss that here. You could see EMCrit episode 378 for that, and get them to the damn OR. And that brings us to CNS, central nervous system infections, meningitis, and encephalitis. And let's break this down into a patient who has normal sensorium and then one who's altered. And I wonder if maybe in your mind, you don't break them down differently at all. But in my mind, that's always the categorization because, and you'll tell me, maybe I'm crazy, but does meningitis versus encephalitis get different antibiotic regimens in your hands? So let's open that up as a broad discussion of CSF as a suspected.
Yeah, if I think there's encephalitis, you're going to see acyclovir because actually I want to back up. If we're talking suspected bacterial meningitis or encephalitis, I don't care if there's not strict indications for imaging. Holy moly, a patient falls down the steps, we pan scan them for trauma. We're talking about a freaking brain infection. Although it's rare, there are going to be patients who do not have focal findings, who aren't severely obtunded, who wind up having stuff like brain abscesses. If it sits in the patient's frontal lobe, you will not find it until you image it or wonder why they're having a seizure 3 days later in the hospital. So I guess that could be a rant. Come on, guys, just run them through the CT. And not because I'm so worried about causing herniation from an LP, but there's other important stuff there that you absolutely cannot miss, and you need to know now. In terms of antibiotics, we talked about if there's any suggestion of encephalitis, you're giving acyclovir, but the antibiotic regimens aren't changed. They start with ceftriaxone. You give vancomycin because pneumococcus may be resistant. Not that we see staph meningitis, but you would also be covering that. And then, depending on the patient, you probably could risk stratify to determine when you're covering for listeria. But the indications are broad. If a patient's alcoholic, okay, that's half my population. So if they're over 60, okay, I guess you're going to be giving me ampicillin if I come in altered. But please get my permission to do a drug screen, Scott, before that gets into my record.
Love it.
And then you're giving steroids.
Absolutely.
And steroids are well established, be associated with better outcomes. But for that off chance, it's one of these rare autoimmune causes of meningitis or encephalitis, you've started the treatment.
So, a quick summary of CNS infections. You're going to start off with the ceftriaxone, 2 grams IV Q12. Then you're going to cover for resistant strep pneumo, and that's either going to be Vanco or in some places they've gone to linezolid, but I think in most places it's still vancomycin for this. If you have to cover for listeria, which is going to be patients over 50 years old, some say 60, or patients who use alcohol, then you're going to add in ampicillin. You will not need to do that if they're using linezolid for their strep pneumo extended coverage, because linezolid will cover listeria. You're going to give steroids, dexamethasone, 10 milligrams IVQ6. And then David's point, because I didn't even know people were doing this, but some people are just getting the LP. They're not getting imaging, and then they're admitting these patients. Always get the head CT because a ruptured brain abscess could look just like a bacterial meningitis. For me, sometimes I will tap before the head CT, but I always still get the head CT. So I did not know people were skipping the head CT entirely. There's one more category, and it's the most annoying of the categories, which is empiric. We don't know the source yet. It might be in for a CT, but we just have to cover these patients because we got to cover our butts. They are clearly sick. We want to give them something. So what is the empiric regimen, David?
Yeah, I think if you play the odds, they have gram-negative sepsis. Again, we're talking about somebody sick. So I think you're going to wind up, if you're giving empiric treatment, you're going to lean towards meropenem because of the emergence of ESBLs. It's not on most order sets, but just
empiric,
thinking through
I've never seen a meropenem empiric.
Just thinking through it.
Yeah.
I understand why people would take a step back because we don't know the source. But if you look at the epidemiology of severe sepsis, it's gram negative. We talked about gram positive. So here's where, without a source, I might go for CT imaging. Chest and abdomen, maybe.
100%.
That's going to sort through some. If you're left with nothing and someone's sick, then if you're not giving, let's say, Vanco or linezolid with meropenem, then you're taking a chance that the patient could suffer because you're not treating the infecting organism as soon as possible. If you accept that chance, that's okay. That's up to you. But thinking through it based on everything we know, the best coverage would be Vanco and meropenem.
I love it. Will your ID brethren, hearing this, they're pulling their hairs out if they were actually listening. They're not, except for the weird folks like you that have done both. But
I don't think they will.
You think they'd be okay with the first dose being that? Because we'd know probably by the second dose what we're dealing with.
Like I told you. Yeah, you mean for the without a source.
Yeah.
No, I think I couched it well enough. It has to do with your risk tolerance somewhat. What percent, it's an interesting question, maybe from the literature, like what percent of patients we diagnose with sepsis, like the real sepsis, is it that we can't find a source? Or at least a pretty good presumed source.
By the second dose, I have to say it's a vanishingly small number.
Yeah. Small.
Yeah. The empiric nature of it always exists until the studies that you sent actually come back, which could be hours. But yes, generally by the time they're going upstairs, we have a source. It's that first couple hours they're in for the CT scan, or the misery of, I can't get the urine. We have to call you to come and get past this stricture. And so you think it's a source, but we don't know. Yeah, I love the idea of just going with meropenem because it anticipated my next question, which was a lot of times they'll give Zosyn Vanco. And then my question to you would be, okay, we finally get the urine and it is a whopping urinary tract infection. Do we now have to add Miro in? And you've just circumvented the question by just saying, no, just give the Miro up front and then you don't have to worry about it.
I know. Maybe my ID brethren will push back on what I said. I have bounced this against kind of the person who's been focused on stewardship studies, prospective stewardship studies. And I think we have consensus. There are patients that aren't that sick or susceptible without ESBL risk factors where I think you don't have to give meropenem. But at the end of the day, it comes down to your own risk tolerance for
All
the
right.
person in front of you. And it's absolutely true. If you give an antibiotic that does not have in vitro activity against the causative organism, you've harmed your patient.
100%. So what am I doing, Empiric? There are some patients who I have a really low clinical suspicion for sepsis. They might be sick patients, but I just don't think they're infected. But I want to cover my butt because sepsis is the great masquerader. And I'm like, I don't quite know what's going on. I love to get some antibiotics in just to make sure. Cover my butt, cover the patient's butt. I give those folks ceftriaxone, 2 grams IV, and I feel pretty good about that. And then I have some time to figure out what the hell's going on. Now, on the other hand, there are patients I'm like, I am sure this is sepsis or septic shock. I just don't know the source. I don't know the source, but I'm sure they're infected. And in those patients, I agree with David. I'm going to give meropenem and vancomycin. And then I'm going to get a CT of the chest and abdomen in addition to looking for all sorts of other sources that could be causing this patient's sepsis. All right, David, what did we miss? What do you want to add?
I think the future of emergency medicine, infectious disease is going to be about more rapid technologies. Maybe they'll be able to break the code on the blood culture and tell us right away what's there and how to treat it because there's resistance genes. Maybe that's a good place to end because I'm hoping that's the future and I live long enough to see it.
And in some places, the future is kind of here now. There's a technology called Verigene. It runs on your blood cultures simultaneously with their standard workup, and it's doing testing for all sorts of species as well as resistance genes, and a couple of hours after the blood cultures start growing. So somewhere around the 10 to 24 hour mark. So not quite the future David wants, but getting close to it. You could get the results of the gene pattern and the potential species of your bug while they're still running the blood cultures. You get from the lab back a indication of what's going on, and you could actually adapt your antibiotic therapy. You could downplay or upplay your therapy. So if you have that, and you very well might, Farkas wrote up a beautiful description of this Verigene technology, and I linked to that in the show notes. And I don't take money from them. He doesn't take money from them. We just think it is cool if your hospital has it to actually utilize it rather than ignore it. Fantastic, man. I can't thank you enough.
Anytime. Thank you.
All right, my friends, that might be the longest one ever. I am so sorry. You'll probably have to listen to this in 2 doses. I don't know how to do it any shorter. I guess I could have broken it up into 2 episodes, but I didn't really see a reason to. It's all on the same topic. There wasn't a clear division point. So there you go. Make it a 2-car ride. You could go to the way to work and the way to back work on this one. I am sorry. I will keep most of them around that 20 or 30 minute mark that we are used to. But this one, it just had to go long. And I thought it was good stuff to talk about. So if you have questions, thoughts, you disagree with something, if you're an ID doc and you think this is crazy, tell me about it. Remember the Resus Leadership Academy. That's resusleadershipacademy.com. We have slots open. There will not be slots open forever because it's on a rolling admissions basis. So check it out. Scott Weingart for the EMCrit podcast saying bye-bye.